All right, and back to this schematic, we're going to talk about treatments now that can improve these off episodes. And it's going to go back to the same drugs that we've talked about in this schematic. And we're going to talk specifically for the treatment of these off episodes. We're not going to talk about dyskinesias today. We're only going to focus on off episodes. So we've treated with levodopa, with or without dopamine agonists or other adjunctive treatments like MAO-B inhibitors, but over time, we've developed these off episodes. So we can first try to extend the on. Remember, you have to get an on in order to extend it. And so there are certain agents that we've already reviewed partially that can extend an on that has occurred. These include the MAO-B inhibitors, the COMT inhibitors that we've already discussed earlier, but also other agents, including adenosine A2A receptor antagonists and NMDA receptor antagonists, istradefylline and amantadine, respectively. So any of these agents, in addition to the dopamine agonists, pramipexole, ropinirole, and ratidogene, which might have been utilized as early monotherapy, the combination of these on extenders with the patient's levodopa can reduce that wearing off, that right side of the graph that we reviewed. However, when we use these agents, the amount of on-time improvement is quite minimal. So this is taken from all of the studies that were utilized to bring these agents to the market. And when patients enrolled into the study, they had a baseline off time, the first numerical column, of anywhere from 3 to 7 hours of off time a day. When these on extenders were added to levodopa, they had a net reduction of anywhere from a half to 2.2 hours. So still a significant amount of off time despite using these on extenders to lessen the wearing off part of off. So in instances where patients are having these motor fluctuations and these off episodes in specific, we want to be able to address the left-hand side of the problem of getting on, the turning on, not having that delayed on or no on part of off. And so in order to affect that side, we need to use what is called on-demand treatments. And there are 3 that are available on the market. There is inhalation of levodopa without carbidopa. So levodopa by itself in a powder can be inhaled through an inhaler. And this has a more rapid onset of effect because it's absorbed through the pulmonary vasculature and can improve that side, that delay of the turning on with the levodopa tablet. In addition, there are 2 dopamine agonists. Apomorphine is both of them. One is available in a sublingual film. The other is a subcutaneous injection. And these 2 agents can take a patient who is off and turn them on, and thus can be affecting that delayed on or no on component. Now, these 3 agents can also lessen the wearing off, but these 3 agents uniquely can turn a patient who is off to on, who is waiting for that levodopa tablet to kick in. Now, once on extenders, on-demand treatments have been instituted, some patients still have unacceptable control with these medical therapies. And in those cases, it may be appropriate to consider surgical management, including deep brain stimulation, as well as other invasive treatments such as duodenal levodopa infusion, and perhaps in the future, other chronic constant infusion therapy.